So today I'll be talking about some work I've been doing for a while on brain imaging, and I've actually spent more than 10 years, close to 15 years, working on brain imaging with the goal of having an impact on mental health. Of course, I'm very happy to see that many of the speakers at this workshop actually do not work on brain imaging, because I think it's very dangerous to think that the only source of interesting information for mental health is via brain imaging. So my talk is not focused on Alzheimer's disease. I've worked a bit on Alzheimer's disease, but it's a bigger picture talk with examples mostly in psychiatry. But really, the setting is the following: if I give you a brain image, and I ask you a bunch of questions, and even if you're an expert, right? Things like, how old is this person? Is he or she at risk of developing Alzheimer's disease? Is he or she depressed? Even an expert cannot really answer those questions. Maybe aging is something that is visible for an expert, but the other questions are quite hard. So basically, reading health from brain images needs a sophisticated data analysis, and one way to do this is to do this via machine learning to basically try to predict mental health. And this is one possible agenda, and it's the one I'll be talking about today. And so I'll first give the hope. We do have evidence that these ideas are possible. I'll go a bit into details, but into methods, but not too much, because I want to stay in a big picture. I'll talk a bit about the Achilles heel of all this agenda, which is that the evidence for prediction can be weak sometimes. And then I'll give a bigger picture of validity in applying those methods in a broader picture. So the first thing is that I'd like to convince people that machine learning can capture non-trivial phenotypes of mental health in brain images. And, maybe all this audience is convinced, but I can tell you that the broader audience of people who are interested in mental health is not. And I think it's fair enough. And I'll be mostly taking examples in autism spectrum disorder. And it's an interesting problem because it's a spectrum disorder, which means that people have very different clinical presentations. And the diagnosis of autism is fully based on symptoms. There is no biological or signal-based definition of autism. So a few years ago, we ran a competition to assess the state of the art. And we did this using fairly rich data, so multimodal data with both anatomical imaging and functional imaging, so resting state MRI data, and on a cohort of 2,000 individuals, which is fairly large by the standards of imaging psychiatry. And this was an open competition where there were strong incentives. There was a fair amount of money to win for the best prediction of autism status, and we left it open during 3 months. What we get out of this is an assessment of the state of the art of prediction in this imaging psychiatry problem that is very reliable and trustworthy. And the best performers got up to 0.8 area under the RC curve. And yeah, that's actually a pretty good number. It's borderline clinically useful if actually done in clinical settings. So that's quite exciting. I honestly did not believe it people would do as well. And we did a lot of post-hoc analysis on the pipelines that people had used. And the number one thing that came out is that the biggest impact was the amount of data. And this is a curve, a learning curve that I'm showing you. And we can see that as we increase data that we give to the algorithm, basically the prediction score goes up. And if we extrapolate, well, it might go up to basically 0.9 AUC, which would be really useful. So my personal feeling about this is that the the main limiting factor is the amount of data. And that's something I've heard people say before. Now, we looked at which part of the data was important. And we did some form of ablation study, removing parts of modalities from the pipelines. And we saw that basically for this problem, functional imaging, so resting state functional MRI, was significantly more useful to predict than anatomical imaging. And that was also interesting to me. I'm not saying this carries over to, say, Alzheimer's disease. Here we're looking at autism, we're looking at a psychiatric disease, and Alzheimer's disease might have clearer anatomical markers. Okay, so my take-home message here is that given labels and enough data, machine learning can extract non-trivial biomarkers of mental health from medical imaging. Maybe you're all convinced, but I think it's useful to see clean validation of this. And so I'll go a bit in the methods because I've spent 10 years of my life working on those methods. So maybe there's a few things I can share, but I don't want to go too much in the details because the big picture is very important. So the first thing I want to share is how we these days do multimodal biomarkers, and there's a very simple way of doing it. Is that we fit modality-specific linear models, and typically those are linear models because linear models are well suited to high-dimensional data. So on each modality, we typically fit a linear model. And then we do model stacking, which is that we combined the predicted outcome value on each modality across the different modalities. And for this, we use a second model. And so typically the way it goes is that we have a model for Fmri, we have a model for anatomical MRI. They give us an Fmri marker, an anatomical MRI marker, and then we combine these. So these become low dimensional information, which then we can combine with a tree-based model. And we can combine it with other information because if you're interested in a problem such as Alzheimer's disease, well, the age of the person carries also predictive information, and you should probably be using it. And now a nice thing about this is that the tree-based model have native and excellent support for missing values, which means that we can do a multimodal biomarker that deals very well with missing modalities, which is a common problem when you have multimodal biomarkers. And so we did this a few years ago with Dennis Engelman, and we were looking at prediction of age. I'll come back to this. And what we can see here is that we're stacking, and sorry, the figure is shifted so you can't see the top, but we're basically stacking more and more modalities. And as we stack more and more modalities, and this is going across not only structural and functional MRI, but also EEG and MEG, you basically see that the error goes down. So stacking multimodality helps, unsurprising. Okay, then to go back to the multiple modalities, for autism at least, we saw that resting state fMRI carried a lot of information. And I personally have been very drawn to resting state fMRI because it's easy to acquire. You're not asking for the subjects to do a task, but it measures functional information. And functional information is something, at least for psychiatric diseases, I think is probably useful. Now, the problem is it has no structure. It's basically, blobs of activation going up and down. And so there's a standard pipeline that has emerged over time is to first define functional regions, then learn the interactions between those functional regions. And it's the idea of a connectome. So basically, we have a bunch of brain regions that are interacting, and we learn how they interact, and then we detect differences. And so in practice, this gives us a pipeline that's becoming somewhat standard these days, is we define regions, we extract time series, we build what we call a functional connectivity matrix, and then we do supervised learning. And So basically, I don't want to go too much into details, but basically there's so many, pipeline options that we can do at every step. How do we define the regions? We could be using all kind of tools to do this. And so what we did a few years ago is we did an absolutely systematic comparison of the multiple choices that we could make at every step. And we did this across, I think, 6 different cohorts. The goal is to find emerging trends to have really reliable conclusions. By the way, I should say reliable conclusions on the methods to use. And so, I don't want to go too much into details in the interest of time, but we tried out the most standard approaches to the various choices in the pipeline. And so, for instance, with regard to region definition, which is the best set of regions to predict? And okay, this is a complicated figure. Just to give you a quick summary, the worst set of regions are the anatomical atlas. The best set of regions are the functional atlases that are learned via not clustering, but linear decomposition methods that give you some form of continuous sparse relations. Okay, so things like ICA or dictionary learning. Now, how do we capture and represent interactions? This is a correlation matrix. How do I model what's in there and capture something that expresses well connections between regions? Now, one challenge that we have is that those correlation matrices vary across subjects in a very complicated way, because basically it's a distributed problem in the brain, and because also of properties of correlation matrices, because those coefficients in correlation matrices are not independent. And those things can be well understood from a mathematical perspective. So we can say, well, maybe we want partial correlations, because partial correlations tend to tease out the link between the brain regions. And the problem is that partial correlations are very noisy. And this is also a problem that is well understood from a statistical estimation problem standpoint. And so here, the specific example I'm giving you, there are 3 controls, and there's a fairly severe stroke patient, a patient that has a very, very big a lesion in the brain. Squinting your eyes, you can somewhat guess which one it is, but it's not obvious. It's this one. But the point being is that we can find a new parameterization that is somewhat in between the notion of correlation matrices and partial correlation matrices. And there's actually very beautiful math that goes behind this. It's related to two points of view. It's either related to geometric learning. So basically, those matrices have a specific structure. And it's also related to the manifold of those matrices, because those matrices are not random matrices. They're symmetric positive definite. Anyhow, I don't want to go too much into details. The interesting story, by the way, is this was done quite a while ago. It was done 12 years ago. And for a long time, application people were not convinced at all. Manifolds of symmetric positive definite matrices, we do brain imaging. Why do we care about these things? So I don't like fighting lost battles. I put this on the side. But now that we're doing our systematic evaluation, we can come back to it, and we can see, what's important. And it turns out that this parameterization really tends to predict better on average than the others. Now, of course, this is a summary of many years of research, so I'm not talking about the dead ends. There are also things that I did that didn't work well. I'm just not mentioning them, right? And last, step, supervised learning step, what should we be doing? Should we be doing linear models, random forests? Should things be sparse or not? So fairly systematic analysis that basically reveals that the simplest models work best. So basically something like a logistic regression with an L2 penalty is what works best. So very simple. It's not surprising from a statistical learning perspective, because we're in fairly high dimension with a number of subjects that are not huge. So we should expect complex models to work best. Okay, So, from a pragmatic perspective, if you have this kind of data, there's a very simple pipeline that works well. You use dictionary learning to learn the regions. You use tangent space representation of the correlation matrices, and you use linear models for supervised learning. And if you want to do all this, we have a software package that's called NILearn for neuroimaging learn that helps you building this pipeline. It's in Python. Okay, so now the problem is in this pipeline, the first step can be quite expensive from a data standpoint and from a computational standpoint. So what we did is that we learned on a huge set of data, 2.4 terabytes of Fmri data. We learned one of those sets of brain regions. And here I'm showing you, and we learned this for different dimensions, 64, 128, all the way to 1024. And so it's all available. You can easily download it, reuse it. You can explore it online. And the goal is to basically simplify your pipelines very well. And we validated this in the paper by showing that it's useful to predict many, many things from brain images. So basically, it's a data reduction that goes from brain images to lower dimension spaces, from 64 to 1024. And we find it's extremely useful for machine learning on functional brain images. Okay. I need to move on. So I quickly want to mention something that's bothering me a lot, is that I think a lot of what we do has potential flaws, and I worry a lot about this. And this is fairly standard. I'm talking to people who probably know machine learning quite well, but we all know that we can't judge the quality of a predictive model on the data that we've already seen. We can build a very complex model that completely overfits the data. And so if we look at the error on the data that we've seen, it doesn't tell us anything. It's meaningless. So the way we do this is we do things like cross-validation. So people did this in the challenge that we set up, the Autism Prediction Challenge. They had a public set on which they did cross-validation, and we left it to them. And we had a hidden private set that we used at the end. And those people were incentivized not to overfit, because the private set was the one that was used to decide who would be the winner and get the money. What you can see is that a few people did disastrous overfit. They had, terribly optimistic predictions. And this is in a setting where the incentive structure does not push people to be optimistic. And if you look at, the way it went is through time, through the competition, as people were working on their pipeline, a bunch of people basically started overfitting more and more. And so they didn't have access to this figure. But we could see people that would improve their prediction in the public set, but not on a private set. So this is basically human overfitting by people who are looking at the public set score and who are just improving things. And the point being is that cross-validation is not an oracle. It's noisy. It's a statistical estimate. It's imperfect. And this can easily be understood from a mathematical perspective. We can put a model such as a binomial model, or we can evaluate this empirically, and we get those kind of confidence intervals. So if you have 100 subjects, the confidence interval are plus and minus 10%. And this goes down as square root of n. And the problem is that those are confidence interval when you're not doing things such as optimizing, looking at this number. But now if you optimize, you're just going to go and explore the tails. And so it's not plus and minus 10%. You can optimize way in the tails. And so we've shown this. I've shown this a few years ago, just basically, playing. I took a data set. I randomly flipped 50% of the labels. So this data set has no information. You can't predict anything useful on this. And then what I did is I tried many pipelines that were all reasonable pipelines that I would believe as a reviewer, as an expert reviewer. And you can see the variation of things that we're seeing here. And you can see that I could have published on a data set that has no information. I could have published a prediction with 71% accuracy. And no reviewer can catch this because this is a reasonable pipeline. It's just, trying a bunch of things and picking the best one, which is often what we do in machine learning research. Disastrous. And does it happen in real life? Well, I can't prove this, but what you can see is that as the number of subjects increases in a publication, in a study, the reported prediction accuracy goes down. My interpretation, and maybe I'm a very negative person, but my interpretation is that there's more wiggle room and people can more easily fool themselves when the data is small than when the data is big. So that has gotten me very, very, very worried, by the way. Okay, so take-home message is that the small sample sizes give us wiggle room that kills my personal trust in publication. Doesn't mean that everything that's being done is wrong. It means I can't read a paper and trust it. So we need to change the way we think. And to summarize what I've shown here, we need bigger data sets for all kinds of reasons, but we also need clinically useful settings. And one of the problems is that we're always missing the label, the interesting label. We might have, lots of imaging data, but seldom do we have the condition. And to take an example, we can take the largest imaging cohort that exists these days, which is the UK Biobank cohort. And we take the whole cohort, it's almost 500,000 people. There's only 500 Alzheimer's disease people in there. Prevalence of diseases is rare. That's a good thing. So how do we change? My view is that we should turn to new outcomes. And let me give you an example. A few years ago, with Fmri, actually Fmri came up to me and he said, I want to predict brain age. And, that sounds a bit meaningless, but okay, we're going to train a model with chronological age. But what we're really interested in is aging. And we're using chronological age as a proxy for aging, where I define aging as the expected age given the image of a brain. And now, if we look at the discrepancy between chronological age and predicted age, this gives us what some people called the brain age delta. And we can see that it correlates with cognitive impairment. And that floored me. That really, I thought that was a really good demonstration that Fmri made of the usefulness of this brain predicted aging. Because some people have a brain that looks older than it should. And that's not a good thing. And so more recently, we've, with Bruno, I'm sorry, Bruno, I know you're in the audience and I'm not pronouncing your name right, with Bruno Vieira, we've looked at how this can be used for predicting evolution of people's cognitive score. I also want to point out some really beautiful work that is being done by Sylvia Villeneuve in Montreal, showing relating brain aging to Alzheimer's disease. I'm not citing her here, but it's really beautiful work. Going further, we want to push the envelope and we want to generalize this notion of proxy mental health measure. And the idea is that we're going to use machine learning on something that is an imperfect correlate of what we're interested in. Here it was chronological age, but we're going to find, imperfect correlates of mental health, and we're going to predict them with machine learning. And we know those are imperfect, but it's fine because they're going to give us biomarkers, which I define as objectively measured characteristics of mental health, and they can be extracted on very large cohorts despite the lack of reliable diagnosis information. And then ideally, we can use them beyond brain imaging and integrate more information about patients. And we can use them for all kinds of applications, such as treatment development, public health policy, or personalized medicine. And so we've done this recently, and we've done this with aging, but also with measures of psychological assessments of people, such as neuroticism or fluid intelligence. And we show that, these brain predicted age, fluid intelligence, neuroticism correlates very well with real-life behavior related to mental health, such as the amount of drinking, of exercise, of sleeping, of cigarettes. And another really interesting thing is that these things, these brain-predicted proxy measures, correlate better than the original one. So we're finding the same thing in the brain age delta, is that we're capturing something in the brain using this training procedure that is related to mental health. Now, I'm going to quickly finish, but to cut a long story short, it turns out that we went a bit further and we looked at how useful brain imaging was, and we can see that for aging, brain imaging really helps to measure aging compared to simple questionnaires about how people feel, what's their education, where they were born, and everything. But for things such as fluid intelligence or neuroticism, those questionnaires are more useful. And I'm talking simple questionnaires. I'm not talking experts, a neuropsychological assessment. And really, I truly believe that we need to give more importance to integrating sociodemographics and those information in image analysis. And in the last few years, I've been working a lot on electronic health records because I really believe there's a lot of information in there and we should be using them more. I won't talk about this. Okay, so we're running late. So I'm going to stop here, and you can see that I recycled this presentation from a presentation I gave at at a conference. Thank you very much.
Thank you. Thank you for a very nice presentation. We can keep, there's some question, but please keep your question for the after the talk of Nargis, and we get back to questions. Just very quick question, yeah. You said that we need bigger data set, and to have bigger data set, we definitely need to collaborate with the medical community to help us to collect data set. And I guess that you have a lot of experiences to collaborate with them. Can you just give us some advice that how we can actually talk with them in a better way, or collaborate with them in a better way, or is there any challenge that you have faced, and now you know that how, if in the future we just face such a challenge, how we should find actually a solution for that?
So first, first part of your question is, I'd like to say, of course we need to collaborate with the medical people. I mean, if we're going to ask, not only the medical people, by the way, we need to collaborate with the public health people. We need to collaborate with people who are interested in mental health in general, even if they're not medical doctors. Of course, I mean, if we're actually interested in solving, a problem such as maybe the audience is interested in Alzheimer's disease, well, we need to talk with the Alzheimer's disease experts. That's obvious. How do we do this? Well, multiple things. First, I guess we respect and we listen to each other. That's a really important thing. Second, we acknowledge that we have different incentive structures and different cultures. And this has gotten me extremely worried. And I with Veronica Shepniniga, we wrote a paper that the preprint was called "How I Failed Medical Imaging," and it was somewhat of a reflection on those challenges. Well, not only those challenges, but many challenges. But really, what came out a lot of this reflection is that we have incentive problems, and here I worry a lot about the incentive problems. We need. And now I'm getting a senior academic, so I need to act upon this and to change the incentive structure of academia, especially computer science. We're looking at publishing as many papers as we can with the highest possible reported accuracy. It's not going to solve any problem unless we make sure that this reported accuracy is meaningful statistically and in terms of application. I guess maybe that's the most important message.
Okay, thank you so much. Again, thank you for accepting my invitation, and it's the second chance for me that invites you for a workshop related to AI for mental health or neurodegenerative disease. And I'm looking forward for our next event to invite you again to be our speaker. Thank you again.
Thank you very much, Ma.